Hi everyone, welcome to me and Michaela's in-service case study project. We have case number 4, which is hypokinetic dysarthria, including LSVT. Okay, we're going to start out with what is hypokinetic dysarthria. According to Duffy, in our textbook, there's a written out definition of hypokinetic dysarthria, which is a perceptually distinct motor speech disorder associated with basal ganglia control circuit pathology. We know that the function of the basal ganglia is to regulate muscle tone, control postural adjustments, regulate goal-directed activities, and scale the force, duration, and amplitude of movements in order to adjust to the environment around us. This can also include learning, preparation, and initiation of movements. We see the effects of this motor speech disorder in all 5 subsystems of speech, but most evidently in prosody, articulation, and voice. At the bottom of this slide, there's some specific deviant speech characteristics that are encountered in those with hypokinetic dysarthria. In the background knowledge given by Viana and Cavacoin in a study they conducted in 2022, they noted specifically that hypokinetic dysarthria was characterized by a reduced vocal intensity, difficulty articulating words, a hoarse voice, and a monotonous pitch. This aligns with our characteristics found below. These difficulties often have a major impact on the individual's ability to communicate with those around them and for them to be understood, or in more technical terms, it will reduce their intelligibility. On this slide, the etiologies of hypokinetic dysarthria are listed. If you look to the right, there's a pie chart with data collected by Duffy that supports that hypokinetic dysarthria is predominantly associated with degenerative diseases, the majority of which are Parkinson's disease. The next highest association would be vascular conditions. This is where our patient in our case would fall. Our patient's medical information gathered included damage from several heart attacks and a stroke. The clinician notes for this case also noted that due to the clinical picture, we have room to believe that damage to the basal ganglia is present, which was mentioned earlier as an important factor in hypokinetic dysarthria.
Okay, so listed on the slide are the characteristics and deficits that this particular patient presented with. We know that he is a 51-year-old man who had myocardial infarctions over a period of 10 days, and this happened 3 years prior to his visit with us. An MRI scan indicated that there were small unilateral lesions to the right putamen, which you can see on the slide, and the external capsule, which are both part of the basal ganglia. And damage to the basal ganglia, as we learned in the previous slides, explains the reason for decreased volume and incoordination or imprecision of articulatory systems. The patient also complained of bad volume, having to repeat himself, not being able to talk in long sentences, and running out of breath quickly. Considering all these deviant characteristics, the clinician concluded that this individual has marked hypokinetic dysarthria and palilalia. We also know that this individual received speech services for a short period of time, but likely became frustrated because he was under the impression that speech services would remediate his speech difficulties. This individual has now agreed to continue to have speech services with an educated understanding that these services will help maximize his intelligibility. So the following slides include different options of approaches that Kylie and I have considered and researched for this individual. We will go through each possibility and conclude with our chosen approach that we have felt is best for this individual. But we also feel that it is important to note here that our patient is not diagnosed with Parkinson's disease, but many of the research, or much of the research for hypokinetic dysarthria is connected to Parkinson's disease, but this patient does have similar deficits to those with Parkinson's disease, so we based our research on those similar qualities. Following the outline of our textbook, the first interventions we looked into were behavioral management options. We were informed that the client in case 4 used a behavioral strategy called finger tapping to help slow his rate and increase his intelligibility. It was observed that this was successful for him. Because this is a strategy that he is already aware of and has access to, it makes sense to consider it as something that we might work with as an intervention in therapy to assist in slowing his rate. To be honest, we didn't find a lot of solid research in this area. Duffy did indicate that several reports document the success of pacing boards or similar tapping strategies. But interestingly enough, the research that we found didn't necessarily indicate a significant difference in this area when collecting data as a group. But when observed on an individual basis, there was there was observed maintenance in speech intelligibility when this strategy was used. For example, Loa et al. Researched the effectiveness of traditional treatments such as finger tapping and metronome use versus the use of altered auditory feedback device such as DAF. What they found is that individually, each person that participated in either group benefited in some way from the intervention, but the traditional rates, such as finger tapping methods, did not benefit as much as the auditory feedback group. Part of the reason they felt that this was the case was because the traditional therapy, like finger tapping, relied largely on self-pacing, which could be an issue if the client doesn't recognize that they need to slow down or if their dysarthria symptoms are so severe that they are incapable of using the method. This is something that we are considering with case 4 as his severity is marked and we want our intervention to have long-term use and effect. There are other methods of rate control that may be more beneficial long-term, such as using the auditory feedback device, but we don't feel that type of therapy is necessary or functional for this individual at this time because of the level of his severity and his ability to implement strategies such as finger tapping.
Okay, on this slide, we're going to look at a couple other ideas for treatment. Some options for treatment can involve different medications. In those with hypokinetic dysarthria, often also diagnosed with Parkinson's disease, they may find their symptoms more manageable with medications like levodopa. According to Duffy, most individuals see improvement in their non-speech motor tasks, but when it comes to their speech tasks, not all studies, and usually to a lesser degree, does it show improvements in speech motor functions. This might be worth looking into since our patient was noted to have some generalized bradykinesia. However, I don't think I would consider it as a number one option due to our patient not being diagnosed with Parkinson's or having tremors where most of the research is conducted. The second treatment I looked into was deep brain stimulation, which had mixed results. According to Duffy, the effects of deep brain stimulation ranged from positive to no effect to negative. A specific study done by Matsumoto et al., they were researching the more precise areas of deep brain stimulation and the effects that they had on speech. This found positive areas in less than half of the participants in the study. In a handful of other studies conducted, they found some improvements on the patient's motor symptoms and sometimes slight improvement in their intelligibility. However, they also found complications like emotional liability, deterioration of intelligibility, and possibly an exacerbated problem of their dysfluencies. We discussed keeping this treatment for later on if the patient deteriorates further. If other strategies aren't really benefiting them, then we could probably try this. But even though our patient fits the criteria of the patient inclusion criteria of some of these studies, I don't think I would choose this right away because the studies are mostly showing variable/mixed results.
The next treatment approach that we felt may be beneficial for this client is the Lee-Silverman voice treatment approach. Just as a little history lesson, Mrs. Silverman, who you see on the slide, was an individual who had Parkinson's disease and was part of the inspiration that helped develop this treatment. It was originally made for individuals with Parkinson's disease, but has been proven to be suitable for many different motor speech disorders. The treatment approach has been the most reassuring for Kylie and I because there is a lot of good quality research that is available to back up our practice with our client. So LSVT is an intensive 4-week speech and language intervention program that asks the client to focus on producing, attaining, maintaining, and monitoring a loud voice. In our text, Duffy discusses how PET scans have been done pre- and post-LSVT treatment, finding that post-treatment new activation patterns were found within the right hemisphere of the brain. Pretty awesome. Ting Pu et al. Analyzed in a systemic review the validity of LSVT in comparison with or in partnership with other behavioral or pharmacologic treatment practices. It was found that patients treated with LSVT showed more significant increases from baseline to post-treatment in transcription when compared with other speech interventions or no treatment. This study also found that the long-term effects of LSVT treatment tended to last longer than other behavioral treatments. Ramig et al. Compared the benefits of only focusing on respiratory treatment compared to LSVT treatment and found that increasing respiratory support alone was not sufficient to generate significant and consistent increases in intensity in these glottally incompetent subjects. In this particular study, there were more significant differences in using LSVT treatment rather than effort for respiratory treatment alone. Those differences included greater articulatory changes and increased vocal loudness. Overall, research has indicated that LSVT improves laryngeal pathophysiology to increase loudness, which in turn affects articulation, facial expression, and respiratory functions of speech. As mentioned on the slide, it's also really important to consider the mental health and motivation of the client, as that does have an impact on the client's progress. On the following slides, we'll discuss the distinctive characteristics of LSVT as well as listen to a short clip of an individual prior to and post LSVT treatment. According to Duffy, LSVT has 4 distinctive characteristics. These characteristics include the intensity of the treatment, which includes 4 sessions per week for a month, as well as homework for the individual to work on. It has a requirement for energetic and high levels of physical effort to increase loudness and vocal fold adduction. It has an exclusive focus on respiratory phonatory effort and focuses on increasing sensory awareness of loudness and effort. These effort-filling exercises include everything from vowel sounds to conversational speech productions. On the next slide, I will show you a video of an individual pre- and post-LSVT treatment. This individual was diagnosed with Parkinson's disease. Although our client has not been diagnosed with Parkinson's disease, the symptoms of a low volume, increased rate, and masked facial expressions are similar. Notice the difference in the woman's speech production and her confidence before and after therapy, as well as the amount of effort she puts into vowel elongation.
Yes, I don't speak loud enough a lot of times.
Anything else?
Hoarse.
Anything else?
I stutter, which I never did before.
Do this for me if you would. Take a deep breath and say ah for as long as you can.
Ah.
Good for you. Okay. Would you say Parkinson's disease has caused you to talk less?
Yes,
Because?
because I stutter and then I can't be heard. If there's noise in the house, like when the kids come over, nobody pays attention.
Say ah for as long as you can.
Yes.
Okay. Do you feel as though people can understand you all of the time now?
Majority of the time, unless it's my husband, and he'll say, "What? I can't hear you."
Good for you.
But I think he does that just to be cute.
I think he does too. Has anyone commented that it's easier to understand you now?
Oh yes, I set some of our friends back when we went to their house and I talked loud. Lou says, "What the hell happened to you?"
Okay, so we decided to go with the LSVT approach for our patient. We know that our patient was disappointed in the inability to completely remediate his speech to how it was prior. He even sought out extra speech services near his home, and for this reason, we think our patient would be a good fit for LSVT. Duffy mentioned that those lacking motivation often saw limited success with this treatment, and so therefore we believe that our patient has the ability to stay motivated and to complete a treatment that requires high intensity and high energy and high focus. Our second reason is supported by some studies that were mentioned in the Duffy text that we read through. And these studies stated that there was a benefit to intensive speech training in people with varying dysarthrias that had different causes, including not just Parkinson's, but strokes and TBIs. For this reason, the research supports that LSVT would likely benefit our patient's hypokinetic dysarthria, even if it's caused by a vascular condition, and provide support to varying deviant speech characteristics that he may have.
Based on a presentation given by LSVT Global through a professional webinar series, we feel that the patient would benefit from having goals that ultimately focus on increasing amplitude and length of sentence production without feeling short of breath. We do not have a baseline data for the length or amplitude of this individual's vowel production, reading, or conversation production, so the numbers here most likely are inaccurate for their short-term goals. But we do know that this individual gets frustrated when he is asked to repeat himself due to poor volume. Therefore, we feel an appropriate long-term goal would focus on effectively communicating with others with an appropriate volume and no external cues. When researching LSVT loud, we found a website that gave examples of daily exercises, intensity, hierarchy, and shaping techniques for utilization of this treatment. The hierarchy we could implement for each short-term goal may be different. For example, we may want to increase the amplitude or duration of like 30 seconds to a minute of the patient's production of a sustained vowel. Or for the second goal, we may want to increase the complexity from phrases, sentences, reading to conversation. This can also include creating more individualized utterances, allowing the use of them to be implemented more in daily living.
So looking forward, we kind of looked forward in two different branches. So I'll start out with our patient. When providing sensory recalibration like the LSVT treatment approach, we're hoping to focus the patient's attention on how it feels and how it sounds to talk at an appropriate volume and rate. This can also be supplemented by educating those who spend time around them when it's appropriate to encourage the use of their strategies and when it's appropriate to compliment them for using their strategies correctly. And this will help hold a patient accountable outside of just their treatment hours. Secondly, it was recommended in their case that the clinician wanted to develop an augmentative system as the time goes on for the patient, and an AAC device could be beneficial to supplement what our patient is working on and could be customized to fit our patient's needs, which would help in communication with unfamiliar listeners. Fager conducted some research in 2019 that discussed the technological support for adults with complex communication needs and severe motor impairments. Some devices beneficial to patients with dysarthria were found to be speech recognition systems and word prediction AAC applications. And then looking forward in the research as we've been studying for this case, we really think more research is needed to support hypokinetic patients that are not also diagnosed with Parkinson's. However, this might be difficult because that is the majority of the etiology of hypokinetic dysarthria. And then also more research is needed to study the best technology assistance for these patients. As technology evolves, we need to find better ways to have it accessible to those patients and to improve speech recognition so that they can be able to communicate with more people around them. And then the following slide is our references for our project. So thank you so much for watching.